Hello, this is Dr. Kamani, licensed clinical psychologist. Thank you for tuning in today. You are here for This Job is Literally Making Me Sick, and this is for Black women in toxic jobs. So, today we're going to talk about the impact that the stress of being in a toxic job can impact you and other issues in terms of stressful conditions and the impact on our physical health. So, we have a very special guest today. So, Dr. Starling, I'm going to have you introduce yourself and then we'll get right into the conversation.
Excellent. Thank you so much, Dr. Kamani. I'm so excited to be here today to talk to you and your audience about migraine. As mentioned, I'm Dr. Amaal Starling. I'm a neurologist who is specialized specifically in headache medicine, and the vast majority of patients that I see have the neurologic disease of migraine. And this is something that is closely associated with stress, and I thought it would be a great discussion to have for your audience today.
Thank you, Dr. Starling. And can you just share in terms of the impact that stress, like being in a toxic job, the impact that that can have on us?
Yeah, so migraine is a neurologic disease, and it's a genetic neurologic disease. It's in the DNA. Even if you don't have a family history, there are mutations that have manifested themselves in an individual's DNA that then gives them the vulnerability to develop migraine disease. And so that's the cause of migraine. But migraine is highly prevalent. In fact, in women, it is even more prevalent than men. So 1 in 5 women have the disease of migraine. Now, again, DNA and genetic mutations are the cause, but many, many things can trigger migraine attacks and increase the frequency and severity of those disabling migraine attacks. And one of those triggers can definitely be stress. Another trigger can be decreased sleep. And we know that when there's a highly stressful situation, it leads to decreased sleep, it leads to unhealthy eating or fasting. And all of these things are actually triggers for more severe disease and a higher disease burden in migraine.
So, from what you've seen in terms of your practice, particularly with Black women who come in and complain about migraines and things like that, what have you heard or seen in terms of how those complaints are being received by medical professionals?
Yeah, so I think even taking a step back from that question is, am I seeing the appropriate number of Black women with migraine? And the
Mm,
answer to that is no. And
mm,
why is that? It's because many Black women are not being referred to a neurologist to be seen and manage their migraine disease. And that's unfortunately because oftentimes health conditions in general and definitely pain conditions that are more prevalent in women are highly ignored and dismissed. And migraine is considered to be what we call an invisible disease. You don't
mm.
see it on a brain scan. You don't see it on an x-ray. You don't see laboratory values that will guide you towards someone having migraine or not. And unfortunately, we have data that shows that pain conditions, specifically in women of color, is actually dismissed, unrecognized, unidentified, and thus undertreated. So they're not even getting to me. And then when they go to, let's say, the emergency room because they're having a very, very severe attack, often again, their pain is dismissed. They're thought to be drug seeking or seeking just pain medications, when honestly, it is a desperate person that is seeking relief of the symptoms that they're having. So there is data that shows that less than 50% of people with migraine are even getting to a doctor who can diagnose them and get them standard of care treatment. There was a recent study that I was involved in that demonstrated that even when we control for insurance, education level, and income, so household income, there are still huge disparities in those individuals who are getting the right diagnosis and standard of care treatment in migraine. So what is the difference if we're controlling for really the typical access to care, right? Insurance, income, education. The difference is race. So this is likely a form of medical racism, especially in women with diseases that affect women more often, and especially in pain conditions like migraine.
Wow, that's really profound because, I've heard a lot in terms of disparities with maternal, in terms of death rates for Black women and for our children when we have the babies. I've heard about that. And even in terms of Black women who have higher degrees, that they have higher rates as opposed to white women with like an eighth grade education. So it's not even about SES or anything like that. So with and so you're talking about like basically there's some gatekeeping that's happening. So let's say a Black woman goes to the doctor, she says, I keep having these headaches, and then the doctor might just minimize that or
Yeah, I think they're just told, oh, you're just too stressed out. You need to relax a little bit more. They might get a brain scan and they're like, oh, but everything looks fine. So, just drink a little bit more water, do some yoga, you should be fine.
ah
Where migraine is one of the most disabling diseases. When you look at the years lived with disability, it is one of the world's most disabling diseases, second to chronic back pain. And so there is such a high prevalence, so many people with migraine, and it can be
yeah.
so disabling. Yet, unfortunately, it is often ignored, and those the number of people and the people who are getting ignored are definitely more so people of color and women.
So in terms of medical racism, can you tell us a little bit more in terms of is it that certain groups are seen as withstanding pain or certain groups are seen as it's not really that serious, or you're not even worthy of the treatment. Like, what's behind the medical racism in terms of what you've learned?
I think that there are so many absolutely false narratives that are still residual from the history of medical racism from years and years and years back. And it's
Mm.
just shocking when more recent studies, there was a study that was done about 5 or 6 years ago where they looked at medical trainees, right? That you think are getting these are not like old school doctors who trained back in the day, but these are now current medical trainees that you think would be getting the most updated information in medical school. And they did a survey, and there are still some medical trainees that believed that there were less pain receptors in Black people compared to white people.
Wow.
There were still individuals who thought that skin thickness is actually thicker in Black people compared to white people, so that they would have less pain. And then on the other side, there is this false narrative that people of color and Black people are hysterical and that they over exaggerate any thing that's going on. So you're getting hit from both sides. You actually
Yeah,
don't feel pain like white people,
yeah,
and the pain that you have is getting overblown. And also the false narrative of that Black people are always drug seeking and they have an ulterior motive when they come to a doctor. And so I think it's a mix of all of those different things.
mm,
Now, there is also, we all have unconscious biases. And I was brought to awareness of one of my own unconscious biases several years ago when I was reading an article about African American men in migraine compared to white men in migraine. And they looked at adherence rates as far as when an African American man is prescribed a medication compared to a white man prescribed a medication. I had the false misconception that just due to maybe differences in healthcare literacy, that there would be less adherence in the African American men compared to the white men, and that was a healthcare disparity. But I thought it was about the healthcare literacy as a result of adherence. And I was wrong. In that study, they showed that African American men actually had higher adherence rates than white men. So I
mhm,
think there's definitely, that overt medical racism, and then there's unconscious biases that many of us have that are also contributing to those disparities.
And how is the medical field addressing that? So the overall medical racism and the implicit bias amongst individuals.
Yeah, there isn't yet a like nationwide or even worldwide effort that is concerted that we're all kind of doing the same thing. I can tell you that locally within our institution, we have really tried to provide ourselves with as much education as possible. So there's an excellent book. It's a pretty hefty book, but Medical Apartheid by Harriet Washington is an amazing resource where it really teaches you about the history of medical racism. We in medical school were taught about the Tuskegee syphilis experiment
Mhm,
and Henrietta Lacks, right?
mhm, mhm.
But besides that, we were not taught anything else
Wow.
regarding the history of medical racism. And to
Mm,
really understand how to treat patients of color, you really need to understand what the history is. So we have had an ongoing book club among our Department of Neurology, and then also some of them, like Medical Apartheid, we actually did enterprise-wide. So all of the Mayo, Mayo Rochester, Mayo Arizona, Mayo Jacksonville, we invited Dr. Harriet Washington, to come and do a grand rounds for more education, and we offered an institutional book club not just within neurology. So education, and then also we've been encouraging the medical school to have a yearly book club for the new class that comes in. There's I have several colleagues that have been involved in anti-racism courses that our trainees will be exposed to. But again, like a lot of this is through like pilot grants that we're getting, and we're trying to figure out what can we initiate as an ongoing effort. And those things are still in the beginning stages. Now, the other thing that we're doing, of course, is if we can diversify the healthcare workforce, that will also be a way that we can attack and eliminate medical racism. And even that has barriers. Just as recently as the Supreme Court
right.
decision on affirmative action,
Yeah.
that doesn't apply to our residencies, but there's going to be a huge downstream
The
effect.
pipeline, right? The pipeline's been cut.
Exactly.
Yes.
Exactly. The pipeline has been cut. So this really increases the amount of effort that medical schools and graduate medical education is going to have to put into this, because now our pipeline has been affected. So unfortunately, I felt like things were slowly, it wasn't fast enough, but we're slowly moving in the right direction. And then now I'm really worried about how we're going to diversify the medical workforce. Another great organization that I'm closely involved with is called Elevate Med. This is an organization that was founded by one of my great colleagues and friends, Dr. Alex Porter. And the sole mission is to diversify the healthcare workforce. They give millions of dollars of scholarships as well as other education and mentorship to specifically Black medical trainees, but also to other trainees of color. But it's really focused on diversifying the healthcare workforce with more Black doctors.
Mm. So what would you say if there's a Black woman and she keeps having these headaches and the doctor are it's just dismissed, like she keeps hearing the same thing over and over again, right? Like you just talked about. How can she advocate for herself to see a neurologist, to get a referral for a
Yeah.
neurologist?
I would actually recommend another resource called the American Migraine Foundation. And the website is American Migraine Foundation, one word, so AmericanMigraineFoundation.org. This is an organization that the professional organization of the American Headache Society, which I'm one of the board members of, it's a sister organization to us. And they have amazing resources there, including one where they have a widget for finding a doctor. And those are board certified headache specialists. Now,
Okay.
there's not that many of us. There's actually only about 700 of us in the nation, and
Wow.
there's like 40 plus million people in the US who have migraine. However, I would recommend if a Black woman is struggling finding appropriate care for their migraine disease, that they find a headache specialist in their area that they can go to. Because we are a small community, we all really receive our education at our national meetings, and at our national meetings, making sure we address health disparities has been a part of our mission. So we've been doing a lot of lectures. This study that I was a part of, I was able to present it at this last meeting in June. A lot of our publications in the Headache Journal about healthcare disparities. So I would feel that a headache specialist would be able to most appropriately address a Black woman with migraine who is not receiving appropriate levels of care and treatment from their current healthcare providers.
Yeah, because I'm just wondering, like if you go to the doctor and you say, wait a minute, this is not helping, I'm wondering, is there specific language that would be good to say, hey, I need to be referred to a headache doctor, or I've tried all these things, these are not working in terms of the advocacy, because I've found that in so many areas for us that we have to advocate for ourselves. So what would you advise in terms of like the language to use about that?
Yeah. I would recommend for them to very concretely ask their provider, I would like a referral to a headache neurologist.
Okay, okay,
Right? So a neurologist that is board certified in headache medicine so that they're
okay.
very concrete about their ask.
Got it,
And
got
if
it,
their
got it.
insurance allows for them to see a specialist without a referral, I would recommend finding a headache neurologist and arranging an appointment with them.
Okay, okay. And can you just share with us, are there certain conditions besides stress, and you said the genetic component too, are there certain conditions that really exacerbate the development or I would just even say the headache getting worse? What are those
Yeah.
conditions?
Yeah, there are many, many different triggers for increasing severity and frequency of migraine attacks. So hormones, so when there are hormonal fluctuations, specifically when the estrogen rate is rising and falling, so around the perimenopausal time period, people will have a lot of estrogen fluctuations. That can be a trigger. And then definitely in women who are having their menses or their period every month, that is resulting in quite a bit of estrogen fluctuations. And then also stress can trigger hormonal fluctuations even
Yeah.
more compared to someone who is being able to manage their stress more appropriately. So hormones is a big thing. Sleep is another issue. Getting too much sleep or too little sleep or inconsistent sleep can be a trigger. And then also anxiety and depression. So anxiety and depression are highly comorbid or they coexist very commonly with migraine. And we
Hmm.
know that there is an association that in those individuals that have a high burden of migraine disease, they typically also have a high number of anxiety and depression symptoms. And it's
Hmm.
unclear, and it's probably both of them feeding into each other. But I definitely see that in my patients that when their depression and anxiety symptoms increase or are poorly controlled, they have more migraine attacks and more inability to manage them with the medications that were previously well controlling them. And then that leads to more depression and anxiety, and then they're in this
Right.
vicious cycle. Other
Yes.
chronic pain conditions. So the pain networks in the brain, I describe them kind of like a muscle. And if those pain networks in the brain are primed by other pain conditions like endometriosis, like chronic back pain, chronic neck pain, chronic pelvic pain, if those other pain conditions are exacerbated or not well controlled, and that pain network in the brain is getting strengthened over and over again, those are individuals that have a higher burden of disease and migraine as well.
Mm.
Allergies can be a trigger for migraine. And then also, there's no specific diet that is helpful for migraine except having a whole food, healthy diet where you're able to avoid processed foods, which has a lot of dyes, which has a lot of nitrates in it, has a lot of MSG in it. And going back to your audience, who are Black women in toxic, stressful job environments, they may be in a situation where they have limited access to healthy foods because they're constantly trying to keep up with whatever's going on at their work
Yeah,
environment. They're eating at their desk. They're
yeah.
not getting, they're becoming sedentary and they're not getting daily movement. All of those things, unfortunately, can be triggers to having more severe migraine disease and more refractory migraine attacks.
Mm. So what about, I'm thinking also for women who are pregnant. So I'm wondering, does that increase too the history if they have a predisposition for migraines?
Yeah, that's a great question. So, again, it's the rate of change of estrogen that can be a migraine trigger. So, yes, in that first trimester, when the estrogen levels are trying to get to where they need to be for the safety of the baby and the mother, that first trimester, there are estrogen fluctuations and there can be an increase in that migraine attack frequency and severity. But fortunately, for the vast majority of women, up to 80% of women, by the time they get to their second and third trimester, their estrogen level is high, but it is the steadiest that it'll ever be in their lifetime for the
Wow.
safety, of course, of that pregnancy. And greater than 80% of women have an excellent response for their migraine disease. In fact, many of my patients may even go into remission during that second and third trimester. And
Hmm.
actually, breastfeeding can be protective. So I think the breastfeeding has been shown to reduce that estrogen crash that can
Um,
occur after labor and delivery. And so,
mhm.
so breastfeeding has been found to potentially be protective in that increased frequency of migraine attacks after labor and delivery. But then again, in that postpartum time period, stress levels are high. There can be postpartum depression or anxiety. There's, of course, poor sleep,
Mm.
poor eating, and just a lot of stress of just having that new baby. And so all of those things can be migraine triggers. But there are options of managing migraine in the setting of pregnancy. And I think that's something I always like to yell from the rooftops, because so many women have the perception, or they've been told by healthcare providers, well, if you have migraine and once you get pregnant, there's nothing we can do for you. And unfortunately, that actually leads to women being so afraid of getting pregnant. We
Wow.
have data that shows that people with migraine, women with migraine, are delaying getting pregnant and then having higher rates of infertility because they're
Mm.
delaying getting pregnant into older ages. And so I
Right.
always tell all my women patients, we always do pregnancy counseling because of the medications they may be on. And then I say, but just let me know if you're thinking about getting pregnant, because there are so many options that we have to offer you for treatment and to manage your migraine during pregnancy. Most women actually do better in their second and third trimester, but we will walk you through it. We'll hold your hand through it, and you will be okay.
Yeah, that's really important too, because I'm wondering if that information about, it's going to get worse, you can't take medication, all those different things contributes to more anxiety, more depression for people who might be struggling with it already. So it doesn't help the situation. And, when you talked about protective factor, you said breastfeeding can be a protective factor. Are there other protective factors for people who might have a predisposition for migraines besides breastfeeding?
Yeah, just in general, you mean even outside of pregnancy? Yes. So, I like to think about migraine as a threshold disease. So, typically, when someone comes to see me in my clinic, their threshold for migraine is likely down here. And stress or a poor night's sleep or barometric pressure changes we've been having a lot of those here in Phoenix because we're about to enter our monsoon. And so, any of those things can trigger a migraine attack. However, once they come to see me, if I can initiate some appropriate preventive treatment options, I can raise their threshold. I can talk to them about what I'll mention is the seeds for success in migraine management. And each one of those things can increase that threshold so that you can live your life. You can have a little bit of daily right? Maybe because of, a child didn't prior,
Dr. Starling, I'm sorry.
sorry.
Dr. Starling, the reception kind of cut off. Can you
Okay.
hear me? Yeah. So when you were talking about the barometric pressure.
Trigger an attack. Or if we raise that threshold with
Uh-huh.
meditation, maybe if you handle different triggers that result in migraine attack.
Dr. Starling, I don't know. I'm trying to hear it, but it's getting choppy again, and you
Yeah.
actually frozen. So I don't know what just happened to the reception. Can you hear me?
Hear me now? I can hear you perfectly fine, but I'm worried that you can't hear me.
I can hear you, but it's choppy. Okay, now I see you back. Okay.
Is
So
that better? Okay.
yes. Can you explain again what you were talking about, the change of pressure and all that? Because I kind of missed that.
Yes. So again, just to repeat that I think about migraine as a threshold disease. So when people come to see me, their threshold is pretty low, and anything can trigger an attack. A little bit of stress, a poor night's sleep, barometric pressure changes, if there's a storm coming through, hormonal changes, and those can all trigger an attack. However, if we can raise the threshold with some effective preventive treatment options, then you can manage, you can tolerate some of those stresses, some of those poor night's sleep, some of those hormonal changes, and they all occur underneath the threshold without triggering an attack. In addition, I always tell my patients to practice the SEEDS for success in migraine management. So SEEDS stands for 5 things. So good sleep hygiene, which means getting to sleep around the same time every night, waking up around the same time every morning. That includes on weekends. That can raise the threshold for a migraine attack, so it's less likely for you to have an attack. Eating regular healthy meals, not fasting, not skipping meals, and also eating a whole food diet rather than processed meals. And then exercising is the second E. So we have data that shows that 20 minutes of aerobic exercise, getting near your target heart rate 3 times per week, is preventive for migraine attacks. So it can reduce the frequency of migraine attacks. The D is avoiding dehydration, so drinking lots of water and making sure your water has a good amount of electrolytes, especially if you're prone to sweating or you're in an area where it's very humid and you're sweating quite a bit. And then the S is directly relevant to your audience, is not stress reduction. I mean, we all have a bit of stress in our lives, some more than others, but stress management. How do we cope with stress? There are healthier ways to cope with stress compared to unhealthier ways to cope with stress. So I recommend evidence-based biofeedback, cognitive behavioral therapy, progressive muscle relaxation, and also, of course, removing yourself from a toxic environment where there's a lot of stress, because that is affecting your health. And so really to preserve your own health and well-being and your burden of disease, sometimes it's important to extract yourself and also use your healthcare provider to help you get workplace accommodations. You have rights when you're working here in the United States. You have family medical leave, you have ADA work accommodations. So find out from Human Resources what paperwork needs to be completed by your healthcare provider to be able to provide you with workplace accommodations, whether that be I need to be able to work several days a week or maybe all the time remotely from home. I have a lot of patients that I've been providing accommodations for them to work remotely at home because they can control their environment, the light, the sound, the pungent smells and odors of the
Stress level.
overcoloring. Exactly, people in the
Yes.
office. And then you can also have workplace accommodations for allowing you to be able to be in an environment that has less stimulation, to be not lifting as much if you have more physical work. So there's a lot of workplace accommodations that we can initiate for patients. They just need to go to their HR, so human resources, find out what the paperwork is, bring it to their healthcare provider, and then talk with their healthcare provider as to what are the things that are triggering attacks for them, and then see if there are accommodations that can be put into place. Those are the rights that people have that they may not always be aware of.
Absolutely. I think that's excellent information. I don't think most people do know about that. So what would you, and you said something, Dr. Starling, that I say all the time to Black women about, if an environment is so stressful that it's causing you symptoms, profound symptoms, it's time to leave. So what would you say to a Black woman, let's say who's watching this right now, and she says, the only time I have terrible migraines is when I'm at work or when I'm thinking about my job. What would you say to her?
I would dig a little bit deeper and I would find out, well, what is it about those environments? And sometimes you have to ask the question and then say, it's okay. You may not have the answer right now, but I want to increase your awareness in those times, right? And be really present in your body, in your mind, when you're noticing that you're starting to have migraine attacks, when you're thinking about work or when you are actually at work. And it may be physical things like the lights, the sounds, the perfumes and smells, but it may actually be the emotional interactions that you're having with people. It may be your supervisor and the inhumane way that they're treating you. It may also be the hours that you're working. Someone may be doing shift work, and their hours are going from nights to days and back and forth and back and forth. And once an individual can better identify what are the aspects of their work environment and about their work that is triggering attacks, then come back to the healthcare provider and be able to say, it's these physical things about my physical environment. Workplace accommodations can be really helpful for that. It's my schedule. Workplace accommodations can be really helpful for that. I've been able to provide accommodations for many of my patients to allow for them to only work day shifts rather than night shifts, or not have as frequent shifting from day to night. So making sure that they do like a month of nights and then maybe the next month they'll switch to days, but going back and forth is too much for them. But then sometimes it might be the emotional environment of that workplace, and really trying to make sure that the patient understands that it is affecting their health.
Yeah.
This is this is affecting their health. It's increasing stress and inflammation in their body, which not only may be increasing migraine attacks, but inflammation may be resulting in many other medical conditions. We know that inflammatory markers may be associated with other chronic pain conditions, a sedentary lifestyle, and those things are risk factors for stroke and heart disease. So these
Wow.
things might actually be physically shortening the lifespan of that individual. So it is almost
Wow.
life-saving to leave that job and find another environment. And sometimes patients will tell me, well, I am the sole income and this is a good income and I have good benefits.
Mhm.
And then after more discussion, they may end up making the decision to leaving that job, finding another job that may actually have less pay or less benefits, but they're actually, number one, happier. But
Yeah.
number two, they actually don't have as much healthcare costs.
Yes.
And
Yes.
so it's
Right?
actually evening out at the end of the day.
Yeah.
So it's a complicated issue, and I
Yeah.
know I don't tell my patients you need to leave your job, because I think that's me speaking from a very privileged situation. And so I really work with patients to try to figure out how we can make it work. But then I also support my patients when they're like, I think I really need to find a different job. And I share
Yeah.
with my patients, I have a lot of patients who have been able to find a remote working environment that's been better for their migraine.
Mm.
I've been able to find, I have a patient actually that I recently saw who is a school teacher for special needs children. So amazing, work that she's doing. But unfortunately, school teachers, they have just gotten into a very stressful and sometimes toxic environment, especially through the pandemic and even now. And I was talking to her just recently about looking into, getting some additional classes over the summer and looking into getting into school administration to get out of the classroom because it's just becoming too stressful for her and it's negative outcomes on her health.
Yeah.
So I work with my patients to talk to them about all those things and provide them all the support and just
Mhm.
really want to empower my patients
Mhm.
to do what's right for them and let them know that they are worth it and they do have options. Really talk to them about self-leadership, right? You do have control, even sometimes when it feels like you don't, but you do have control to say no and look elsewhere.
Yes, I
Um,
say that all the time about options, right?
yeah,
Because when we don't feel like we have options, then that can contribute to depression and anxiety too. And Dr.
yes,
Starling, you said something too in terms of, you really work with people to help them arrive to their own conclusion. So you said, you know what? Okay, let's collect some more data about when do these headaches happen? What do you notice? So that helps people have a greater awareness of ways that what's going on around them can affect them physically and mentally. And then from there, having those open, real talk conversations with them about the stress can really harm you and it's not conducive, right? And so when you think about people saying, I want to stay at a job because of the pay or the benefits, but if the job is making you sick or contributing to being sick, it doesn't make sense. Yes,
exactly. It doesn't make
yes,
sense. And also, if the job is exhausting them of all of their not just physical, but emotional and spiritual energy all throughout the day, and then they come home and they just crash, and they're also then there's this whole added piece of guilt of not being there for their family, their
yeah,
partners, maybe their
yeah,
children.
yeah.
Um, and then it adds to that stress. So it's
Mhm.
interesting, sometimes when I talk to the patients about, I really want you to be present and aware of when you're having an attack, what is that environment? Or when you're at work or thinking about work, what is that environment? Interestingly, I've had the experience with some of my patients because I'll see them back, sometimes every 3 months or 6 months, or if patients are on a stable regimen once a year. And
Mhm.
interestingly, once they have increased their awareness and they're really present,
Mhm.
then they actually have already shifted their job before they come back to see me.
Wow.
And they're like,
They've
oh,
already
I'm
taken
doing better.
action.
Exactly. And it's funny because they're like, when they come back to see me, they're like, oh, I'm doing a lot better. And at first I'm like, ooh, what did I do? Like, what medication did I give them that they're doing better? I'm like, so what do you think made the difference? And they're like, I switched my job. And I was like, oh my gosh, that's
Wow.
great. I was like,
Yes.
and then I'm like, what are you doing now? And I really like to find out from patients who are doing better and who are in a better workplace, what is it that you're doing now? How is it different? Because that's
Mm.
then education that my patients provide me that I can share with other patients, and let
Mm.
them know, yeah, I had a patient who was in a similar work situation as yours, and now they switched to X, Y, and Z, and they're doing better. So again,
Mm.
just talking about others' experiences and making sure that patients also understand that they're not alone,
Yes.
and that other people have taken action,
Yes.
um, helps increase their courage as well.
Yes. What are some of the themes that you've heard from patients who've left, and what are they saying is better in this other work environment? Because when I talk about leaving toxic jobs, I just say you have choices. So you can get another job if you want, you can own your own business, you can do a combination of both. So what are your patients typically saying in terms of what's different in these better work environments?
Yeah, so remote working has been a really big thing that a lot of my patients were, suddenly exposed to because of the beginning and the peak of the pandemic. And then they realize that their migraine is actually doing better. And
Mm.
so that's definitely one thing that I've been talking to patients about is, can you work remotely or can you find a job where you have more remote days? And I think along with that comes a job environment where you have autonomy, and that definitely there's increased autonomy when you're working from home, but also even if you're not working from home, but the lack of autonomy in a job environment where you're constantly have people over your shoulder criticizing
Micromanaging.
what
Yeah,
exactly
yeah.
that seems. And I mean, there's not a study that has been done with that, but I'd be curious to be a part of one and do one, because I can almost guarantee that job situations in which people are being micromanaged
Yes.
likely increases more stress and increases more migraine disease. So a job environment where they have more autonomy and more of a basically have more autonomy and are not being micromanaged seems to be better for my patients who have migraine. And then also those doing daytime shifts rather than nighttime shifts. And then for some of my patients, they struggle a bit more so in the morning compared to the evening. And so some of my patients who've been able to start work mid-morning rather than getting to work at 7 a.m. or 8 a.m. seems to be better. And along with that, just a flexible work schedule. So where they're able to, go into work a little bit later. Let's say if they had a migraine attack the night prior or in the middle of the night, they're able to take their medication and they're able to, be able to recover before they have to get into work. And so that flexibility seems to be really, really helpful as well. So more autonomy, more flexibility in their work schedule, less night shifts, and then the remote working seems to be big themes in people who have had a more positive work environment.
Awesome. And so, in terms of treatments, what are some medical treatments for migraines?
Yeah, so there are kind of two categories of treatment for migraine. So in an individual who has migraine disease, they may have a certain number of migraine attacks per year, per month, per week. Some of my patients have multiple times a week, multiple migraine attacks. So there's a huge
Wow.
spectrum of disease. And so I
Mhm.
like to use the analogy of asthma because I feel like people understand asthma a little bit better than migraine. So there's a huge spectrum of disease in asthma. Some people who have asthma attacks a couple times in their life. Some people who have asthma symptoms on a daily basis. And so for people who have infrequent asthma attacks, all they need is a rescue inhaler or an
Mm.
as needed inhaler that they use when they're having an attack. But for people who are having very frequent attacks, maybe multiple times a week, maybe severe attacks where they're having to get additional medications or steroids or having to go to the hospital or even urgent care, those individuals may need something to manage the underlying disease for prevention of asthma attacks because you can't use your rescue inhaler that many times. It'll actually worsen your asthma, it'll give you other complications. So,
Mm.
similarly, in migraine, everyone who has migraine needs an as needed regimen, meaning, what do I do when I have an attack? Everybody needs that type of treatment. And there are a lot of over-the-counter medications like Advil or Motrin, which is ibuprofen, Aleve, which is naproxen. Excedrin has caffeine, which has benefits, but then also if someone takes it more frequently, it can contribute to more headaches. So
Oh,
you have to be very
no.
sparingly in using that
Wow.
medication. And in fact, and then there's prescription medications. And the first line of medications that are prescription are called triptan medications. So there are 7 different ones: sumatriptan or Imitrex, rizatriptan or Maxalt, and there's 7 different ones, and they all end in the second half of the word as triptan. And those are the first line prescription medications to treat individual attack.
Mhm.
Now, with all of those as needed medications, the over the counter ones, including Excedrin, which is definitely guilty for this, and then even those triptan medications, if someone is using those medications more than twice a week, they can actually start contributing to more headaches.
Oh my gosh, that's terrible.
It is, and it's actually written on the bottle because we had a policy change that went through the FDA, through the headache advocacy communities to have it written on the packaging,
Oh,
but it's really, really, really tiny fine print, so
yeah,
people don't really see it. In
right.
addition, those medications, when you take it too frequently, it is hard on your body, even if they're over the counter. Ibuprofen is hard on your kidneys. Overusage can lead to kidney problems.
Wow.
Overusage can lead to bleeding ulcers in your
Oh my
stomach and
gosh.
intestines. And then too much Tylenol is bad for your liver. And so self-medicating with those medications over the counter, once you're having more than 1 or 2 attacks and headache days per week, is not a good option. So
Mm,
again, then you need to talk to your primary care doctor or your neurologist or headache neurologist about a preventive medication to manage the underlying disease so that you're not having attacks as frequently. And there's
okay.
many options for those. There's oral medications that can be used that you would take every day. Some of
Mhm.
those are nice because they can help with migraine as well as insomnia, or
Hmm.
migraine as well as depression, anxiety, or migraine as well as blood pressure. But then
Hmm.
there are also some medications that are migraine specific. There are
Mhm.
some that are once a month injectables that a patient administers themselves at home. It comes like in an auto injector, like an EpiPen kind of.
Hmm.
And then there's also injections that I do for patients in my office. So we use Botox injections for the treatment of chronic migraine in a
Hmm.
specific protocol once every 12 weeks. It's a very effective treatment for migraine prevention for many patients. So there's a lot of different options. It's important for someone with migraine to talk to a healthcare provider that has good knowledge about the various options so that they can identify the right one given their medical history.
So with the prevention medications that you talked about, do they in any way increase the likelihood of headaches or migraines?
They don't. They don't.
Oh,
They
awesome.
actually decrease the likelihood of
That's
attacks.
great. That's great.
In fact, one of in the same this seems circular, but one of the biggest risk factors for having more migraine attacks is having a higher frequency of migraine attacks. So, for example, when you have less than 15 days per month with headache or migraine, it's called
Mhm.
episodic migraine. And then
Mhm.
the vast majority of my patients actually have chronic migraine, which is 15 or more days per month with headache or migraine. And so
Mhm.
there's a study that shows that if individuals have, let's say there's two people, one who has 2 migraine attacks per month and another one who has 8 migraine attacks per month.
Mhm.
In a year, if we look at those two individuals, it is likely the person that had 2 migraine attacks per month probably still has about 2 migraine attacks per month. But the
Mhm.
person who has 8 is more likely to have converted to a chronic migraine pattern where they're
Wow.
having 15 or more headache and migraine days per month. So it's really important to intervene early to
Yeah.
make sure that as needed treatments are effective and that prevention is started. The
Yeah.
threshold for prevention is when someone is having 4 or more migraine days per month. That
Mhm.
is when a conversation about preventive treatment options should be started.
Wow. That says a lot. That says a lot. Now, what about people who might be watching this and they say, I don't believe in medication. I just want to go the natural route. What do you say to them?
I say you have options. You have many options. So there are multiple evidence based preventive treatment options that don't involve a medication or even an injection. So sometimes the conversation about the injections, like nerve blocks or Botox injections, some of those patients like that because they like to hear that this is something that isn't going into my bloodstream, it's working right underneath the skin. And so that's a good option for them. Other people are like, I don't want anything else in my body. I don't want
Yeah.
an injection. I don't
Yeah.
want a medication.
Yeah.
And the great news is that there are biobehavioral techniques that are evidence-based. So that's the biofeedback has been shown to be effective for the prevention of migraine. Cognitive behavioral therapy that is focused on migraine, typically delivered by a health psychologist, has been found to be effective prevention for migraine, sometimes in studies even better than some of the medications that we have.
Wow.
And then also we have a number of what we call neuromodulation devices. So these are non-invasive electrical or magnetic devices that they work by changing the electrical environment of the nerves and the brain cells, and they have evidence for treating individual attacks as well as for the prevention of migraine. And so these devices are a great option for many patients who really want to avoid as many medications as possible.
So the devices, like how often would they need to use it? How big or small is it? Like where do
Yeah.
you put it on your body? All of those details.
Yeah, so those are really important details. And again, the American Migraine Foundation.org website has some great videos as well as blogs. I think if you put in, I did a video for them a couple years ago. So if you put in like Starling and migraine and you go to videos, there'll be a number of videos that pop up just from a Google search. And there's one Facebook Live that I had done regarding devices that can
Okay.
actually, I have the devices, so I was like showing people how to use them. But there are 5 FDA cleared devices for migraine right now. There's one that's called the Cephaly device. It's a device that you have a little sticky pad, you put it right here on your forehead, and it stimulates the nerves right here, the supraorbital and the supratrochlear nerves. And by doing so, it actually feeds back to the migraine part of the brain, and it reduces the likelihood of migraine attacks if someone uses it every night. It's a 20-minute treatment. Sometimes it can make people sleepy, so I have people just use it prior to bedtime, so it helps if people have insomnia sometimes. And then they can also use it as needed when they're having a migraine attack throughout the day. There's another device that's called the gamma-core device. It's applied here on the neck. It stimulates the vagus nerve, and by stimulating that vagus nerve, it can prevent migraine attacks and treat a migraine attack that is already ongoing. There's another one that's called the Nerivio device, and this actually is an armband, and it electrically stimulates nerves in your arm, but those pain fibers that it's stimulating in your arm actually feeds back to the base of the brain called the brainstem, where there is pain modulation, and it increases, or basically it decreases pain perception and decreases the likelihood that your brain is going to have a migraine attack when used every other day. And it also treats an ongoing migraine attack. There's another one called the Relivion device that stimulates the supraorbital nerves here and the occipital nerves in the back of the head. And that also works similar to the Cephaly by stimulating those nerves, but it does the additional ones in the back. And then another one that's called central neuromodulation. So it's brain neuromodulation by using a magnetic pulse. This is called single pulse transcranial magnetic stimulation. It's a device you hold on the back of your head. You push 2 buttons. You just hear a click, but it's actually administering a magnetic pulse that changes the electrical environment of the brain cells. And again, when used 3 times a day, it can reduce the frequency of migraine attacks, and then it can also stop a migraine attack once it's ongoing. So there's all these different devices that are available for patients. Different ones work for different patients. One of the huge pros of this is, of course, minimal side effects, really well tolerated, and for many people, very effective, and it's not a medication they're ingesting into their body. One of the barriers to these devices is that they're very rarely covered by insurance.
That was my next question.
Yeah.
Yes.
Unfortunately, they're very rarely covered by insurance. They have varying costs depending on the device that ranges from one where you can purchase it for like $500-ish. It does have like a 90-day money back guarantee. So if it doesn't work for you, you can return it and get your money back. Other ones work on a rental. And so there's a certain amount of money ranging from $99 per month. Some of them are more expensive, like $250 per month. One at one point was like $600 per month, but I think they reduced that.
That's
They can
ridiculous.
be very pricey. But if people have health savings accounts or flexible savings account, since these are prescription treatments, as long as you write a prescription for the patient, they can get it reimbursed through those types of saving accounts. And it is a potential option, and especially given that now a lot of patients have high co-pays, high co-insurance or co-deductible. I don't even know all the different terms from an insurance perspective, but like I was counseling a patient about one of these devices, and I was telling them, but one of the barriers is it can be expensive. And they're like, well, how much? And I was like, well, I think this device is about $200 to $250 a month. And they were like, I'm spending $200 a month for my rescue medications.
Wow.
So it's really no different. And I was like shocked by hearing that.
Yeah.
Speaking of which, another great tip for your audience is if it's a generic medication, sometimes going to this website called GoodRx, so GOODRX.com is a great way. You just put in the name of the medication. Sometimes cash pay generic medications are cheaper paying for them cash than going through your insurance. I don't understand it. I don't get it. It's weird, but it is a fact.
Those are really good resources. So, I know we're winding down soon, but when you said that, it just reminded me of just access, right? And so, what if people don't have the money? They just have to, now they have to rely on, maybe if they don't want to take medication, their only choices are you don't take it or you take medication, but they don't even have the access. So, I'm hoping that some kind of way the medical field addresses that too, because that just seems like issues of disproportionality as well. So, Dr. Starling, as we're winding down, can you share with the audience what is the work that you do now and how can you be contacted?
Yeah, so currently my day is split up in the clinical work that I do and seeing patients. I'm also very much involved in medical education as well as involved in research. So clinically, as mentioned throughout this talk, is that my focus is on patients with migraine and other headache disorders. I really do want to do my best and my part in addressing healthcare disparities. So when I have patients who are Black men or Black women, I know that I need to provide them the most equitable care possible. And
Mhm.
then in addition, with regards to medical education, I am a program director for transitional year or interns. And so I provide them with medical education on healthcare disparities, as well as teaching them specifically about headache disorders and migraine. And then my research actually is on neuromodulation. And so I participate in a number of clinical trials, as well as advancing all other migraine treatment options. I also have advocacy as a part of what I do in my career, both in the research that I do, but then also playing a role in the national policy change and advocacy. Go to Capitol Hill through an organization called the Alliance for Headache Disorders Advocacy. Every year we have Headache on the Hill where we talk to Congress about migraine and headache disorders. And in the last 5 years, it has been a top topic of talking about healthcare disparities, whether that be about Black men and Black women, about our about our American Indian and Alaskan Native population, and about our veteran population who has the veteran population, especially those with less access to care, are a lot of people of color. And so we've been focusing on that population quite a bit because of poor health outcomes in that population. So those are the things that I do on a
Wow,
daily
you
basis.
have your hands
I
full. You're
love
doing a
my work.
lot. Yes.
Yeah, stuff that I love and I'm passionate about. I'm also on Twitter, so people want to, and now it's called X, I guess. It changed in my phone this morning, but whatever it might be, you can still find me at Amaal Starling, MD, and you can direct message me on that. I'm also on Facebook, Dr. Amaal Starling, and you can send me a message on that. And then, of course, if you are looking for a headache specialist in the Southwest, me and my colleagues would be happy to see you, and you just call Mayo Clinic General Scheduling and be able to see one of us as a patient.
Awesome. Okay. And with Mayo Clinic, Do they accept all insurance, or how does that work?
Yeah, so Mayo Clinic, depending on the department, accepts different insurances, and it also depends on the location. But I can tell you that insurance is a barrier to access to care at Mayo Clinic, which is why we have a lot of our services in community clinics as well, which then don't require insurance or don't require the right insurance. But that definitely is a potential barrier.
Okay, okay. So everyone, thank you so much for tuning in. I have learned a lot from Dr. Starling, and I'm sure you have too. But you heard directly from her, not just me, about a toxic job can be harmful to you. And please be aware of the signs if that is the case for you. You do have options if you have a migraine. So we talked about advocacy, we talked about different treatment options. So please just follow up on these things if this is your experience. And also, please give this video a thumbs up so that YouTube knows you share this video with other women who are in similar situations. And if you have not already subscribed to my channel, please do so. Lifting as we climb consulting wellness services. So everyone, thank you so much for tuning in. I was keeping an eye on the chat, and so Dr. Starling, they're just saying thank you so much for this great information. So this has been a very, very, very informative. So if you have seen this video, but you're like, wait a minute, that was a lot, just go back and watch it again and also share it with other people as well. So everyone, thank you so much for tuning in, and I'm signing off. Dr. Starling, if you just stay on for one moment, okay? Okay, bye-bye,
Thank you so
everyone.
much.
Take care.